We're getting into a Healthy Friday conversation this morning, and we're going to be looking into something that has a lot of people wrapped up, and we're asking our questions in terms of, so exactly what happens? Why is it that I get a cough and a flu right now, and then maybe I go into hospital, somebody gives me antibiotics, and then I'm fine. And then, gafla binvu, just a few weeks after that, I start to sniffle and cough again, and it forms the basis of a conversation that we're having this morning and asking ourselves the question, what exactly does happen? A Healthy Friday conversation today is going to be had with Professor Rodney Adam, who is in the hot seat of the Situation Room this morning. He's a pathology and infectious diseases specialist, and he's here this morning. Professor Adam, good morning.
Good morning. It's nice to be here.
Thank you so much for being here. And, you know, of course, in joining us to celebrate Radio Maisha, whether we are all going to celebrate today, whether we like it or not. So we're glad that you're here joining us on a Healthy Friday conversation. It's an important one. But before we get into it, shall we do something which is a bit of a ritual that we do here? We go around the African continent every week. We land in one country and we come back with the proverbs and from that country. And so we're going to share that with you today. Mark will tell you which country we're in. He'll share the proverb, and then we would like to get your interpretation of the same. Fair enough?
I think so.
Okay,
good stuff.
Let's go.
So this country is in West Africa. Have you been?
My first time in Africa was in Liberia.
There you go.
So yes, I have been to West Africa.
Liberia. You know, there's Zanzibar. You know, there's an island called Zanzibar.
Yes.
You know, there's Mombasa, right?
Yes.
You know, we've got the Tsavo. You know, we've got beautiful Mount Kilimanjaro and Mount Kenya. You know that?
Yes.
And then the first place you choose to come to Africa is Liberia.
You just go.
That may have been before you were born.
Indeed. Well, there's a country called Ghana, whose proverbs today are what we are discussing, and they say that knowledge is like a baobab tree. No one can encompass it with their hands. Knowledge is like a baobab tree. Baobab tree is huge. Like its trunk is maybe the size of this table, right?
There's some that are bigger, actually.
Yeah.
Yes, in fact, I was in Mombasa or in Diani a couple of weeks ago.
Yeah.
And they had a tree with a trunk bigger than this.
Mm-hmm.
So yes.
Mm-hmm. Mm-hmm.
Then
so
it continues to say, no one can encompass it with their hands. So what do you think about that?
I like it because there's so much knowledge out there, and each of us, even if we know our area of expertise well, there's still so much that we don't know, and so much more that's remaining to be discovered. Mm-hmm. So it's exciting, and it's very relevant to science and medicine.
Mm-hmm.
Indeed.
Oh, thanks.
Indeed. And so there's a lot more that you can find out. You never actually exhaust anything. And in terms of knowledge and understanding, those are some of the things that we want to be able to look into. We want to have conversations around things that are relevant. We want to have conversations and gain knowledge and understanding about things that we face or on a daily basis. And whether those are societal issues, whether those are governance issues, and for now, those are health issues as well. Let's take a look at some things that have been happening over the last few months. When we've come off of COVID, and I say come out of COVID because essentially we did, didn't we? We saw a recurrence of flu-like symptoms, you know, every now and then. And people told us, well, it's a strain of COVID, it's a strain of something. But more recently than that, in the last couple of months, and it could be because of change of weather or whatever, but you're the expert, so you will tell us. We have seen that there has been a reoccurring of these symptoms, that somebody could get a really terrible, cold, the coughing, the sweating, the aches and pains and all of this. And then before long, they're in hospital getting treatment. In some cases, antibiotics have been prescribed. And then they're on the path towards recovery, or so we thought. But then, thereafter, the sniffles are back. And we are starting to ask ourselves questions about these strains. We are seeing them we're seeing it in children, we're seeing it in adults. There's just this big almighty bug that seems to be going around and doesn't seem to be swatted off by anything. What are we seeing, and what could all of this be attributed to?
Well, first, there are many viruses that cause respiratory illness. COVID is one of them. Right now, influenza has been the most common, but there are many that are going around all at the same time. Another big one for younger children is called RSV. In the laboratory, we diagnose those various viral infections, and we're seeing all of them. So usually when somebody gets sick with a respiratory virus and then gets well and then gets sick again, it's an infection with another virus.
Of the same family?
Not the same family. If it's influenza the first time, then maybe it'll be one of several other respiratory viruses the next time.
Okay. The assumption is that when one is taking antibiotics, you're doing this for a bacterial infection. Can you have antibiotics for a viral infection, for which you told us respiratory illness in some case are viral, some also bacterial?
The answer is these colds, coughs are almost always viral. And the antibiotics that we have are only for bacteria. So antibiotics make no difference. Often what happens is that somebody's been sick for a couple days, they take an antibiotic, and then they get better, and they give credit to the antibiotic. But in fact, it was the body's immune system that took care of it, and that's why the symptoms went down.
So why are we prescribing antibiotics for viral infections?
We shouldn't be. And that's one of the really important things. First of all, there's the idea that antibiotics are totally safe and with no downsides. And that's not true. There are serious side effects that can happen, so don't take them if you don't need them. And then secondly, on a more global idea, the more we use these antibiotics, the more bacteria will become resistant. And we have a real problem with bacterial resistance now throughout the world, and specifically here in Kenya.
Now, Doc, there is the issue of antibiotics being sold off the counter, and that's been a big problem because I remember a while back even the doctors' fraternity raised an issue with that, and government moved in to equally just have a discussion around that. But still, antibiotics are being dispensed off the counter. Just how serious of a problem is that to a society and the resistance that continues to be felt in Kenya?
Yeah, I'm glad you raised that. That's an important consideration. In fact, I was here in Kenya for many years before I even knew that there were laws not allowing pharmacy to dispense antibiotics without prescriptions. But as we all know, that's not enforced, and people are doing it routinely. And that is a big factor that's contributing to the bacterial resistance here.
So what happens with bacterial resistance exactly? Walk us through that process.
Well, when you take antibiotics, the bacteria are very clever. They will eventually become resistant to whatever you use, or there will be new bacteria that have always been resistant. And now, when you get an infection, it's caused by a resistant organism. So the antibiotics are selecting for the more resistant organisms.
So here we have resistant antibiotics. That would mean that for anybody who's attacked now by a bacteria and needs to be treated, that doctors need or pharmacists need to crack their head to find a combination of drugs that would then go into healing this individual. And in terms of the country and its expenditure in taking care of its people due to the resistance that we continue to face, just how much of a burden is that to, say, the government? Or an individual for that matter, because then they pay from pocket?
Yes, it is a big burden. And for the various kinds of infections that do need to be treated with antibiotics, what often happens is that the antibiotics that are needed are expensive. They are available only intravenous, so it's very difficult to treat those infections. And even more concerning for the longer term is that there are no really new drug classes that are in the pipeline right now. So we're running out of effective drugs, essentially.
You know,
We're saying it so calmly.
I like how the gentleman to my left speaks of very doomsday events with such nonchalance that it is scary. Every once in a while, you get on Kenyan social media, and then they will tell you about the latest superbug. And for some reason, it's always some STI. Then they'll tell you there is super gonorrhea, for example, which is untreatable and things like that. Set us at ease or at fear, it depends, of what superbugs already exist in the country.
Well, there are many.
Many.
We have all of these, as you're describing, these superbugs are the ones that are highly resistant to antibiotics. And yes, there are a number of them, including a couple of the sexually transmitted infections, including certain kinds of hospital-acquired infections. And for the occasional one, there is no effective treatment. And for others, we may be back to drugs that are toxic or not very good for treating those.
When you say hospital-based infections,
Acquired infections, yeah.
that's scary, isn't it? And what does that mean?
Well, when somebody is admitted to a hospital, whatever they're being treated for, they will also be at risk for hospital-acquired infections.
Okay.
And when they occur, they're often on somebody who has been treated with antibiotics, so they're very often resistant. And that happens at every hospital in the world, and every hospital in the world is trying to make sure that's as infrequent as possible.
But where within the hospital does this actually happen? What are we talking about? That where would you then be able to re-get, or what's the word? Be reinfected?
Well, it can be anywhere in the hospital. It can be surgical infections. It can be infections related to other procedures or devices. It tends to be more common in the critical care areas just because of how sick people are.
You see, every time you go to a hospital, there is this thing in the country where you hear that mostly private hospitals are really pushing to have people admitted in hospitals and whatnot. But when you think of it, in order to deal with matters to do with hospital-acquired infections, would be admit as less people as possible. Let people just get in, get treated, be serviced, and go. Then you lower the chances upon which one would acquire all these infections. But that doesn't seem as though it is a concern for the hospitals, or the government is not raking in to address that. And hence we see these numbers continue to increase day in, day out. So should there then be a need for government to come in with a policy in terms of how long someone should be in the hospital when they're seeking treatment, the number of hours they spend in, depending on veracity of the illness they have?
I'd say that would be very difficult to do at a regulatory setting. Really you're depending on the judgment of the physicians there for how long somebody needs to be in. One thing that's happened recently at Aga Khan Hospital is a big expansion of home health care. So that means that when somebody is on the way to recovery but not ready for actual discharge, sometimes having a nurse go to their home once or twice a day is enough to continue that recovery. So that's one thing that can be done. And of course, yes, there are occasional people who are admitted to the hospital who didn't really need it. I don't think we have seen that to be too much of a problem at our institution.
Okay. I want to look at this issue of reinfections and the use of antibiotics, and that it is, Prof, every time a child, let's take children as an example, every time a child has the sniffles, and even before seeing a doctor, which they might present with headache, fever, and it's not been tested whether it is a virus or bacteria. We know that fever can come with viruses, but we also know that bacteria, rather antibiotics, will not treat viruses. But we are uncomfortable with this whole idea of the virus must pass through the system, which we've been told. You must let it pass because it will pass. And that all you can do is treat the symptoms. You can't treat a virus. It'll go. But we are uncomfortable with that imagination that my child will be sick in bed and is uncomfortable and I need to give them lots of fluids and, up their fruits and vegetables, things like that. But it is the uncomfortability of that situation that makes one want to go for the antibiotics, which will provide temporary relief, but not cure you of the thing. How do we start to divorce ourselves from this thing that an antibiotic is the be-all and end-all of every single illness?
That's a really good question and a really tough one to answer. Now, there isn't even any relief from the antibiotics. You just add side effects when you give them for a viral illness. And these cold sniffles are almost never bacteria. So we're talking about viruses. But even when I was in the U.S. before coming here, I would say it's a lot easier to give an antibiotic than to convince people why they don't need one. And that was in a setting where they couldn't just go down to the local chemist and buy one. So here it is actually more challenging because even if you tell people that, very often they'll just go to the pharmacy and be given an antibiotic.
I had another question before, but now I want to ask this. Because when you go to the hospital, most times in Kenya when they test your blood, they'll tell you, you've got high levels of certain antibodies, and we can tell it's an infection. They rarely tell you whether it's viral or bacterial. And 99% of the time, you'll walk out with antibiotics.
Yes.
I can tell you for a fact that's what happens across. So is it possible with the current laboratory capacity of Kenya for a doctor, whoever is testing you, to know whether you have a bacterial or viral infection?
Really good question. And the answer is that very often that can be done without any laboratory tests. There's a frequent desire among doctors that they want to treat a number. So they'll look at an elevated white count and say, this is a bacterial infection. I remember seeing that in somebody who visited our place after having done Kilimanjaro. And they had some minor symptoms, white count was more than 12,000. They said, this is a bacterial infection, you need antibiotics. And in fact, it wasn't. So sometimes those kinds of lab tests are actually counterproductive when you can do a clinical evaluation that doesn't include laboratory testing and be confident that this is a viral infection.
But you see, we also live in a society where if the only other way, again, from a patient's perspective is the results that come from blood work is the one that I believe the most. So that means there is a breakdown of information to the patients, and doctors also find it as though, like you said, they want to treat a number. So how do we then have a conversation such that the patient understands that it is not always about the blood work that gives you the best result, but then again, just clinical process would give you the best results that you need? How do we marry conversation and treatment?
I wish I knew the answer to that, because that's a tough one. And it's not just for patients and families, it's also for physicians, where there is this default to looking for a number to treat.
There is a danger when now there's the overprescription and then the overusage and overdosage of antibiotics. Let's look at that, apart from the resistance, what it actually does in the bodies of those who take them, as often as we are seeing is happening in society today. We're having a conversation this morning around the resistance that is built up by antibiotics, maybe in some cases where you actually do not need them. Our Healthy Friday conversation today is with Professor Rodney Adam, pathologist and infectious disease specialist, and we're looking at use and misuse of antibiotics. Is it a contributing factor to the rise in cases of common cold and flu? And now we've already established that these are two separate issues, but then somehow we seem to put them together. I think we've established that common cold flu they are viral. Can we take the stance and say here on this show this morning that if you have been taking antibiotics for a common cold, flu, this influenza that we've been seeing running amok, that you've been taking the wrong medication?
That is correct, and the best medication is simply for treating the symptoms. Don't use antibiotics in those settings.
Okay. Now, what is the danger of prolonged use of antibiotics when it is unnecessary?
So what we've already talked about is that the person who takes those antibiotics then is colonized with more resistant bugs that are a risk for new kinds of infections. And also something that people often don't realize is that our bodies are normally made up of many, many different kinds of bacteria. And that's on the skin and the intestine and other parts of the body. And in fact, we have more bacterial cells than human cells in our body. And those bacteria are, for the most part, helpful. And when you disrupt that, you have a whole chain of events that will actually lead to a lower level of health rather than optimal health.
Mm-hmm. For children, does this pose a greater risk than it does in adults?
Potentially, yes. And in fact, there is some evidence that multiple courses of antibiotics for younger children result in increased risk for obesity. Just one of a number of potential problems. So, yes.
So there is, you see, even in instances where prescriptions have been administered to individuals, and I'll give an example of TB, where someone has been given the medications, but they don't, after a while someone feels better and they drop from finishing the dosage as prescribed. Later there is now the resistance TB that comes in and becomes even difficult to treat it. So what are just in instances where antibiotics have been issued, have been prescribed, what are the dangers in not finishing the dosage as prescribed?
Well, this is really a totally different story and may run counter to what people have said and believe. And for other, let's say, true bacterial infections that need a course of antibiotics, the risk there of a shorter course is not resistance. It's just relapse of the infection that you're treating. So if you have a urinary infection and the treatment should be 3 days and you do only 1 day, then the urinary tract infection may come back quicker. But that's not a setting where you have an increased resistance problem. TB is a special example because it normally requires 6 to 9 months of treatment. And what happens is that people take the drug until they feel better, so maybe just a month or two, and then they stop it, and then the TB regrows. And when as the bacterial organisms multiply, that's when the resistance can start. So otherwise, the shorter the better.
How many of these super infections are currently untreatable in Kenya?
I don't have a number for truly being untreatable. I think that number is very small.
Okay.
What's much more common is that they're difficult to treat, either expensive antibiotics, highly toxic antibiotics, and those kinds of things.
As you say that, I'm just thinking, I'm at home, I'm not feeling too well, I'm thinking of going to hospital. How would I know as an individual, either when I get treatment or just before I go to hospital, are there signs and symptoms where I would be able to tell for myself that this is a serious thing? Let me take an example of the flu. So a lot of people have complained over the last 3 months in Kenya that they've gotten very heavy flus that have literally put them down as though they are super sick. Is there a way for Kenyans to know? And the reason why I ask this is, as a typical Kenyan, we fear hospital bills. And you go to hospital, the closer you feel to death. The more pain, the more... That's when you go to hospital. The best thing to do is go to the pharmacy, describe your symptoms, and then they'll give you something, right? So how would someone be able to know, either before going to hospital or while taking the first course of medication, how would someone know that this is more resistant, more difficult, a disease?
How would you know?
Yeah, that you're asking a good question that's very difficult to answer because
I hope so.
These
that's the hot seat.
These are difficult situations. So, for example, with viral infections of the respiratory tract, sometimes your breathing is impaired enough that you need help with that. And there, it might be a matter of treatment with oxygen if you're at that point. And that was common with COVID, more common with COVID than with the other viral infections, that people would have inadequate oxygen. There's just one example, but it would be nice if we have ongoing health education for the non-medical public so that it's easier to make those decisions at a household level.
Okay.
See, the doc talks in terms of the need to have more education in terms of medical awareness. And it is something that in this country, people only go to hospital when they are sick, when you feel as though you can't move, as opposed to regular hospital visits, regular checkups, for you to just know where you are so that in case there is anything, you're able to treat the illness and deal with it. So how critical and how important is it for Kenyans pretty much to have a culture of once every year, twice a year, to just go for medical checkups to know how they are, because your body is your resource?
That's really separate from the whole discussion about antibiotic resistance. But when you do those, you can go through all the aspects of your life and your health. Are you using good nutrition? Are you getting the right amount of exercise? Are you controlling risk for diabetes, high blood pressure? So there are many things that can be done with these ongoing checks that should be done.
What should we, because again, I'm going back to the children, because parents are often met with panic when it comes to, when children aren't feeling too well. And in this case, where it is a viral infection, usually the request even comes from parents. Give me something that is going to take care of these symptoms. Whereas the patient, to actually apply the patient to see the virus live out. So the two questions: number one, what is the lifespan of a virus within the host, the body? And then what can you actually do to make this person more comfortable?
In terms of the duration of the virus within the body, it depends on the virus itself and also the individual who's infected. For one person, you may have influenza there that's 3 days, another one where it's 5 to 7 days. And then sometimes afterwards, and especially with influenza, people will cough for several weeks.
Yeah.
And when they do, of course, then we want to know, well, is it just a cough after a viral infection, or do they have something else? So sometimes there will be an evaluation that's needed then. In terms of the symptoms, something like paracetamol, if somebody has fever or just muscle aches, can be very helpful, and that's the way to focus.
How prepared is the Kenyan health system for these developments in the medical field, where antibiotics may become less and less effective as time goes by? That the kind of diseases we'll be seeing could change in their intensity of manifestation. Is Kenya prepared as a country and as a medical system to actually be able to cope and adjust to this reality that seems eminently coming?
Well, my initial answer to the question is, what can we do that will improve our ability to respond? So one is that there are some drugs that are backup on this high end that need to be made available. But if they come in, we also have to make sure they're not overused. So I think there's a lot that can be done there. I think the whole issue of pharmacies giving antibiotics without prescriptions needs to be revisited for enforcement. But also it's a global problem because of the few drugs that are in the pipeline now that will make a difference.
Right. You mentioned, and I think this is the bombshell that Mark had alluded to earlier, is that there's very little now on the market, and this is a global issue, of antibiotics, which we know that they are needed when it comes to the bacterial infection segment of things. That now there are very few antibiotics available that will actually do what they're meant to do, because of the fact that we've overused them, we've overprescribed them, probably in cases where we shouldn't have, etc. Now, does this pose a big enough threat at the moment for us to be worried about? And then how can we be sure, is there assurance guaranteed then that when you do go in with a bacterial infection for which you need an antibiotic, that it will actually work?
That's going to be a big challenge for this country and all the other countries because we can't go back to zero. Before penicillin was released, we really didn't have
anything,
the antibiotic resistance. But as we've used more and more antibiotics, those have become greater. And the antibiotics that we're using now are actually bacterial products, either directly or we use synthetic means to adapt them. So there haven't been any really new classes that have emerged. So there has to be a lot of innovation on the scientific side as well. And my worry now is that with some of the decreases in research funding that we see in the U.S. and elsewhere, that might get slowed down. So again, it's a global problem, and we all have to work on it.
One of the easiest way one would assume that Kenya would be able to deal with these is to address the one action plan that was put in place in 2017 that just puts structure around dispensation of medicine on the counter, talk about antibiotics, and that would help deal with the resistance that we talk about, with the overuse or misuse of antibiotics. So in terms of on a policy level or the implementation and the regulations just being upheld, what should the government do, or what should the medical fraternity do to ensure that the 2017 policy is actually upheld?
Enforcement. That's my quick answer, because that's not going to change without a level of enforcement that makes it more difficult to for the pharmacies to prescribe.
Yeah.
And of course, doctor education as well,
yes.
because some of this is coming from doctor prescriptions that aren't necessary.
Because even the 2017 research that was done was actually found that doctors themselves do not have the knowledge when it comes to prescription. So yes, I agree.
How do we, as a people now, the society in general, when you go to the doctor and he prescribes for you antibiotics, how do you as a person know whether you need those antibiotics or not? Because you have two problems in this country. First, doctors hate to be questioned. You know, they in fact, they don't talk to you. You say your symptoms, then they write on a piece of paper, then they tell you, go to the lab, right?
Yes.
Or they get the lab results, they write on a piece of paper, go to the pharmacy. How do I get informed enough to know whether I need this antibiotic or not? Or even sometimes, is this the right class of antibiotics for what I'm going through?
I don't have a great answer there. It comes back to the issue of education for the doctors and education for the
Patient.
public. And perhaps not going in so quickly for mild illnesses.
Yeah. Wait, that's an important statement.
Yeah.
Not going in so quickly for mild illnesses. Explain or expound?
As we've talked about, most respiratory infections are viral. And we're talking about somebody who is otherwise healthy. So when you don't necessarily need to run to the doctor at the onset of symptoms if it's following that expectation. And some of that is about just training the non-medical public for when to go in and when not to go in.
Wow.
How would that be a game changer when it comes to our seeking behaviors for treatment?
Yeah, health-seeking behavior, of course, is not my expertise. And I wish I had good answers for how to change that, but it is an important thing. There are so many things where people delay far too long for going in, whether it's for HIV, for cancer, or whatever. And so saying this for respiratory infections is sort of the other side.
The other side, yeah.
When do you go in and when do you not go in?
So when we look at, pathology, obviously, this is an area of expertise for you. And we also then look at around issues of surveillance, that you look and say, this is where we see the path, this pathogen, for example, where it's going, how it has affected previously, and what it is likely to do before it then goes on and dies off. So you have that surveillance mechanism in place. Now, because you can do that, that's why everybody else in this area is then able to say, well, we've seen the behavior. And then because of that, we can then can diagnose this particular medication. You can see the path of it, and you can see that at some point, if resistance has been built up, we can now say, this is why this drug then can no longer work. Because of that, I assume. Please stop me where I'm wrong. Now, if we're able to do that, shouldn't we then be able to employ that same surveillance and say, look at this footprint of the disease burden currently? That's why you can go in and a doctor can say, yeah, we've seen so many of these cases come into hospital recently. Should we not be able to use the same idea of surveillance to say, well, this is what is happening. Do not administer this drug. Do not prescribe this one, but let's look at something else. Can we not use that same idea?
Now, we've been talking about viral respiratory infections. So I'll make it clear that we're going down a different route now in terms of infections that truly do need to be treated. And let's say urinary infections, because they most of the time will require antibiotics. And there are some medications that are more likely to be active than others. And, globally, it's very common that urinary infections are treated with the antibiotic that's likely to be effective and without even requiring laboratory tests. That's more difficult here because the level of resistance. So sometimes you have to test and say, this antibiotic will be effective and this one won't. So there are some examples that fit with what you were just saying and asking.
Yeah. Okay. What would then be? Because we ground it and we say that, look, these are the dangers that lie. This is the practice that we've seen, obviously established that there are certain things we should not be doing. And it's going to take us some time to wean ourselves of this behavior. And when we look around society, there are folks who don't even go into the doctor for many reasons, whether it is financial, whatever. They're able to say, well, this is how my child is feeling. Palm to head, there's a temperature, there's a fever. Then we can just go into the local pharmacy and say, mtoto ni mgonjwa, we take something, antibiotic off the counter. We take some time to wean ourselves off of that with current conversations like this. However, if there were 3 things that we could say today that needed to be done to kind of set ourselves in this situation that we are in and how we can protect ourselves further, what would those be?
All right. My list of 3 would be, one is to enforce requirement of prescriptions for antibiotics. Secondly, train the non-medical public on health-seeking behavior. And thirdly, to train the physicians to a greater level on the diagnosis and treatment or non-treatment of infections.
Okay.
That's a tall order, I know.
Yes. Yeah.
Let's talk about curbing the spread of the disease itself. When, let's say, an individual goes and finds out I have a superbug, what are the protocols that the doctors or the medical care professional should give the person in terms of how to make sure this does not become spreadable? At the same time, I'm thinking about what you said about hospital-based infections. What can hospitals actively do to actually make sure that if they discover patient X got a superbug, what do they then do to make sure that this hospital is not a superbug center?
Yeah, that's moving into the issue of hospital infection control.
Yes.
And all of the hospitals have some kind of infection prevention and control system in place. And in fact, at Aga Khan, we have some very good people who are in that program, and we actually do a workshop for training infection control people from other hospitals as well, including our own Aga Khan hospitals as well as the public sector. So good infection control, limiting antibiotic use will delay the spread of some of those.
Yeah.
And then within the hospital, the single most important intervention is clean hands. So you don't go from patient to patient without appropriate cleaning of the hands.
Okay, this is interesting because if you were to be a bystander in a medical facility, clinic, dispensary, hospital, whatever the case may be, we assume that because we see medical practitioners wearing gloves, that is okay. And I wonder how many times those gloves are actually changed from seeing Mark to seeing Adam to seeing Dennis to seeing Ndu. Do we take notes of how many times those gloves are changed, or we just assume because that they are latex that they're not going to hold on to anything? How important is that as an intervention for some of these things that we're talking about?
Yeah, that's a good question. Gloves should only be used for one patient, and it doesn't take away the need for cleaning the hands with an alcohol rub or at a sink with soap. Either one is an acceptable approach. So if you use gloves, it's a supplement, not a replacement.
It's a supplement and not a replacement. Well, I mean, some of these things vital that we have conversations around them, and that's why we do some of these things that we do. Professor Rodney Adam has been here with us this morning, looking at the importance of knowledge, really knowing when we're dealing with one thing or the other. And we want to thank you for being in the hot seat on our Healthy Friday conversation this morning. Thank you so much for all that you've shared, and we look forward to keeping these conversations front and center of discourse.
Thank you very much.
This is the Situation Room, the only way to start your day.